My name is Ashley Lozat, and I will be moderating the webinar this evening. Tonight, please welcome Dr. Michael Jurgelewicz, who is actually one of our own here at Science for Health. We are extremely fortunate to have him working at our main office as the Director of Clinical and Product Support. You may be familiar with him through his blogs, his emails, or his role in our monthly Nutrient Roundtable calls. And you may have been even speaking to him if you've called into the office with a product question. Today, Dr. Mike, as we know him, will be presenting a functional medicine approach to autoimmune disease. Dr. Jurgelewicz has been studying nutrition and wellness for the past 10 years. He has a bachelor's degree in both health and wellness and in anatomy, and is a doctor of chiropractic. He is board certified in nutrition by the American Clinical Board of Nutrition and a diplomat of the Chiropractic Board of Clinical Nutrition. Dr. Mike's academic training and clinical experience in functional medicine position him as an authority in the management of a variety of chronic health conditions. All right, go ahead, Dr. Mike.
Thanks for the introduction, Ashley. I would just like to take a moment and welcome everyone, and thank you for joining us on tonight's webinar. Most of the patients that I see from a functional medicine standpoint have autoimmune conditions. It's typically what I've attracted over the years. If we know what causes the immune system to attack itself, and we know some of the triggers for what causes the malfunction of the immune system, which we do, we can successfully treat these conditions. There are different autoimmune diseases within all specialties, and all these are looked at differently. However, they all have many of the same common triggers. So we can take this similar approach really in treating all autoimmune diseases. Autoimmunity occurs several different ways. First, there can be a mistaken identity where the body attacks itself. This can occur with a virus where there's tissue destruction and it appears to be foreign to the body. In addition, this can happen with heavy metal toxicity such as mercury. Second is by a process called molecular mimicry. And this occurs when the body makes an antibody to a protein in the body that attacks itself and appears to be foreign to that specific antigen. These antigens can be several proteins in the body, and these antibodies attack its own tissues. And the third is by the development of T cells through the immune system. This can be affected by our genetics, stress, and environmental triggers. And environmental triggers are really what we work with a lot in functional medicine. And these can be food triggers such as gluten, food sensitivities that trigger inflammation, as well as anything that's coming in with the food such as toxins or molds. And obviously the nutrient status of the person. Really, before we get started, I kind of wanted just to share my story and what's got me into functional medicine in the first place and how I've gone down this road. And about 15 or 16 years ago, I was just having a normal routine blood panel with one of my primary care docs, and they ran my thyroid antibodies, and I had a positive antibody for Hashimoto's, but obviously all my normal thyroid markers were normal. So the traditional medicine approach is there's nothing wrong with you, you just have the antibody for hypothyroidism. But you appear fit, you appear healthy, so there's really nothing wrong with you. At that point, obviously, I wasn't through my training in chiropractic school, and I didn't really have all the board certifications in clinical nutrition. But as I went through training, I came across these other issues, and I would go to my next GP who didn't test my antibodies, but then things started to affect my T3 and things being low in that nature. So I kind of went down the route of really trying to get to the cause of these autoimmune diseases for myself, and then I obviously try to help patients out with that. Once an antibody becomes positive, for example, for like Hashimoto's, like your TPO, your thyroid peroxidase antibody, there's a 97% chance you're going to have Hashimoto's in 7 to 10 years. So if we know this, then what are we going to wait around and wait for something to happen when we can really take care of that now? So one of the things I first wanted to show up here was this was a National Geographic, and it goes over the cost of healthcare. And if we look here, on the left, I mean, it's kind of hard to see on this slide, but it has all these different countries and what they spend per year per person on healthcare. And on the right, it shows the average life expectancy of these people. And if you see, everything's kind of in the middle here, but that red line all the way at the top is the U.S. So the U.S. is actually spending $7,290 per person, which is over double than all these other people, and we have a lower life expectancy. So obviously the current model that we're doing is not working. You can't employ these acute care models to these chronic conditions. So that's what I want to share today. And we got a lot of practitioners on the phone. We have some patients, and some people are very, very advanced in integrative functional medicine. And I just want to show a few cases and kind of how I've done some workups and had success with that. So we're first going to start with some basic concepts here. I touched on this a little bit, but Scientific American back in 2007 put out this article called Predicting Disease. And this really has to do with that whole antibody process that I was talking about with me and my personal life. So there's all these different antibodies for all these autoimmune diseases and conditions. And the environment is going to affect those as well. So there's a high percentage that you're going to have this disease process or this autoimmune disease process down the road. It's just a matter of time. Once that gene gets expressed or that antibody becomes positive, it's pretty much a marker for future destruction of that tissue. So traditional medicine really is just going to look at you and look at how your symptoms are, and they're going to treat those symptoms. They're not going to really change the environment. And of course, that disease process is going to get progressive and get worse. But if we can really look at some of these environmental influences from an epigenetic standpoint and really how these environmental influences affect this gene expression, then we can turn this, think of like a dimmer switch down so much so that you go in what traditional medicine would say is remission. I just wanted to share these are just some of the basic blood chemistries I do on most patients as a normal workup. Most traditional doctors do this. This is going to be your CBC with differential, your normal Chem 14, a lipid panel. I add a hemoglobin A1C, insulin, homocysteine, cardio-CRP, an iron panel, and then your vitamin D. And obviously, when you're doing autoimmune disease workups, you're going to be testing antibodies and stuff as well, but this is more of the base foundation, and you're going to do a lot of other things as well. I add A1C and insulin a lot because sugar in the blood is going to stimulate your immune cells to release inflammatory molecules. So you definitely have to address that in all autoimmunity, really to get a handle on it. Homocysteine is going to really show us how we're methylating. B12, folate, that sort of thing. And obviously, if people are having issues really getting homocysteine down, then we really have to look at some other things like MTHFR and see if people have some of these SNPs out there that can be causing some issues. Some potential environmental triggers that I really look at in functional medicine, and that's pretty much where we work the most from an integrative standpoint, is looking at gluten. And the first thing we want to say is, how do we assess or address if someone has an issue with gluten? There's lots of testing out there. The normal celiac panel you're going to see with the gliadin antibody and the tissue transaminase from Quest is really just not sufficient. There's a lot of false negatives. There's many proteins that are part of gluten that really need to be assessed. In all honesty, there's some good labs out there that can do some pretty good testing, but we're still not probably there yet to have the most accurate, really reliable gluten testing. And that really just gives us an answer of a yes or no. Do I have a problem with gluten? So in all honesty, it's one of those things you can pretty much just eliminate from your diet. It doesn't cost anything, and you can see how you feel. Food sensitivities, this is going to be a lot different than your normal food allergy. Food sensitivities usually go through a process called an IgG response versus the normal food allergy is going to be an IgE. And an IgE is that RAS test that the traditional allergist uses. So he does the normal skin prick test and sees what you're allergic to. Now, with IgEs, which are the food allergies, most people know what those are. People have immediate severe reactions to these, where with the IgG reactions or food sensitivities, you get very vague symptoms. And there can be things such as joint pain, fatigue, headaches. They're actually a lot more common than the IgEs, and they can cause inflammation because the IgG response is inflammatory. Another thing we look at is nutrient deficiencies. I assess this usually through organic acids in the urine and through RBC measurements in the blood. Stress and hormone imbalances, I address this a lot through with organic acids as well, which I'll show you a little bit in some of the case studies that I have. And then from a dysbiosis standpoint, really every single person who has an autoimmune disease needs to be doing stool testing. And the really big disconnect here is how many of your patients have autoimmune diseases who see a rheumatologist, and how many rheumatologists are doing stool testing? 0. So all these systems are interrelated, and they have to be looked at together, and they can't be segregated into these individual specialties. And that's where a lot of the people miss the boat on this. When we look at infections, we're going to look at things in the stool and the blood. Toxins, they're going to be heavy metals. They can also be environmental xenobiotics and different pesticides that come in with our foods. If it's not safe to breathe, how can it be safe to eat? I think this is a pretty cool picture just because there's lots of people that react to foods that they eat, but it's not so much sometimes the actual food, but really what's on the food and what comes in, what gets brought into an environment with the food. Death begins in the colon. A Russian biologist, PhD, Elie Metchikov, he was the first person to have a rationale for the use of live bacteria in the prevention and treatment of infections back in 1907. So over 100 years ago, he hypothesized that replacing or diminishing the number of bacteria in our gut, you could normalize bowel health and prolong health. I mean, I think this is pretty profound. We knew this information over 100 years ago, and I mean, medical research, what we have is well further along than what's actually in medical practice. So there's lots of things that we can dig up in the medical research to really support what we're doing. When we look at intestinal barrier dysfunction, that's simply really just leaky gut from a layman's standpoint. The gastrointestinal tract's 80% of our immune system. When there's inflammation present, those tight junctions in the intestinal mucosa can become damaged, inflamed. As a result, you get gaps in the lining of the GI tract. These toxic byproducts in the digestive tract can be absorbed into the bloodstream and carried through to the liver. As a result, the molecules of food and toxins are absorbed into the GI mucosa. Then eventually they affect systems throughout the body where you're getting inflammation, people are getting joint pain, skin disorders, autoimmune conditions, food sensitivities. Back in 2009 in Scientific America in August, Alessio Fasano has a great article called Surprises of Celiac Disease. And in that article, he breaks down really this whole process through celiac and what we've learned. And you put the environmental trigger, which in celiac disease is going to be gluten, with a genetic predisposition, which is pretty much our filter. The gene has to get expressed. And then we look at the leaky gut, and that's the intestinal permeability. So you have to look at autoimmunity as really this three-legged stool, or I should say perfect storm. If you take any one of these three things out, then the autoimmune disease can't sustain itself. But when you have all three things, it's the perfect storm, and then you get an autoimmune condition. For people who have celiac, if you remove the environmental trigger, which is gluten, they're fine. So, but obviously we can't get rid of their genetic predisposition. That's our genetic makeup. So that's a constant. But we can remove the environmental trigger, or we can heal the intestinal permeability. But you can't heal the intestinal permeability and continue to eat gluten, because that's just going to, keep the process going forward. And this is just, I have this in a PDF. So I mean, if you guys ever need to reach out, I can always give this article. And this just kind of shows the whole breakdown of zonulin opening up the intestinal between the tight junctions and letting the gluten through, and then the whole immune response and how it gets into the bloodstream. The discovery of zonulin prompted us to search the medical literature for human disorders characterized by increased intestinal permeability. It was then that we first learned, much to the surprise, that autoimmune disease, among them celiac disease, type 1 diabetes, MS, rheumatoid arthritis, and inflammatory bowel diseases all have as a common denominator intestinal permeability. In many of these diseases, the increased permeability is caused by abnormally high levels of zonulin. And in celiac disease, it is now clear that gluten itself obviously exaggerates or promotes the zonulin secretion. So for people that aren't really familiar with zonulin, zonulin's a protein that's going to regulate the permeability of our gut. We have tight junctions that pretty much hold our mucosa cells together in our gastrointestinal tract. And realistically, we're only supposed to have like diffusion and certain ions and stuff that pass through there. Now what happens is if zonulin levels get high, the permeability of the intestine goes up. And now all of a sudden we eat our normal foods, and then some larger proteins can actually pass through the intestinal barrier. Now it gets into our bloodstream because it's only one cell layer thick, this intestinal mucosa. The body recognizes that as being foreign, which the immune system's right there, and then you get these immune complexes to all these different foods, and that's how people develop all these food sensitivities. So there was a study in 2012 I just added in here that showed the vitamin D researchers examined specific mechanisms by which vitamin D might act on the immune inflammatory pathways. So what they did is they incubated human white blood cells with varying levels of vitamin D. They exposed them to lipopolysaccharide, which is a molecule associated with the bacterial cell walls, known to promote intense inflammatory responses. Then cells incubated with no vitamin D were in a solution containing 15 nanograms per milliliter, which is really, the normal level for vitamin D is 30 to 100. So 15 would basically be a severe deficiency, meaning nothing. And then they incubated 30 nanograms per milliliter and showed significant reduced response to the lipopolysaccharides, which was the highest levels of inflammatory inhibition was seen with 50 nanograms per milliliter. So a lot of us doctors, you know, we kind of shoot for anyone who, for optimal levels of vitamin D, really to have above 50 nanograms per milliliter. The lipopolysaccharides, they're large molecules that are found in bacteria, which are basically endotoxins. And if they're absorbed, they cause a really strong immune response. And there's different labs out there that can test all these different proteins and really show if someone does have a leaky gut. But again, that just gives us an answer as a yes or no, not really so much what the course of treatment would be. So biochemical individuality. That's really where the functional medicine approach shines, because we have patients that have similar symptoms, but they can have totally different test results. And then you have patients that have similar test results that can have completely different symptoms. And this is where the protocol-driven treatments fail, really in a traditional medicine standpoint. So the real take-home here is really to do testing and don't guess. So there's different metabolic markers or functional markers that you can really assess different nutrients. And this is what I do with organic acids. And these are urinary metabolites. So basically number A would be your nutrient, and then what happens is you need this or cofactor, I should say, and then where it's blocked with the vitamin insufficiency is really an enzyme. And if you don't have enough of a cofactor, which in this case would be like, say, B12 or folate, to drive that pathway, then a certain metabolite gets kicked out in the urine. And that's how you can really show if someone has a true deficiency. Traditional doctors use kind of what I showed at the very beginning of my presentation, complete blood counts, metabolic panels as a general screening tool to really rule out their health problems with their patients. But in addition to the standard tests, functional medicine integrative doctors use organic acid tests to identify imbalances that occur in the body. And these happen long before they're ever going to be picked up on a CBC or a metabolic panel. They're really just products of our metabolism that can identify nutrient deficiencies. So when these specific cellular functions are blocked, whether it's an impairment or lack of cofactors such as nutrients, those organic acids are going to spill in the urine. And obviously, we can take increased nutrients to help drive those pathways. And organic acids really been around for quite a while and used by integrative docs for a long time, but they're just not commonly used by mainstream physicians. I test all organic acids on all my patients. Abnormal concentrations of organic acids can really show us these functional markers of the metabolic effects on these nutritional deficiencies. And this just shows us really the stages of energy we get through our food. So we have our fats, carbohydrates, proteins, and this is really just the Krebs cycle. And it would have been a lot more exciting if we saw it this way in school. But you can see in each of these biochemical steps or these processes, it shows what nutrients are required to drive that step. So if a certain organic acid gets high in our urine, then you can see, well, we have a deficiency of, say, lipoic acid or carnitine. And it's a way to really have specific recommendations for our patients. So the first case study I want to kind of walk people through is a case with rheumatoid arthritis. this is a 59-year-old male. This was back in 2011. He complained of joint pain, fatigue, depression, anxiety, and he had high blood pressure. He was on a few medications here, beta blocker, calcium channel blocker, and an ACE inhibitor. And right around the time I started working with him, this was before he was diagnosed with rheumatoid arthritis, but probably within 2 months when I started working with him, he was put on Plaquenil. It's a lot less aggressive than a lot of those chemotherapeutics. But the interesting thing is here are some of the labs we started with. RA factors 14, that's high. C-reactive proteins through the roof, almost at 36. Sed rates pretty high as well. They're the normal labs through LabCorp. Then we have some labs right below it during that week that were done at the hospital. ANA is positive for, obviously that's going to be another antibody for autoimmunity associated with things like lupus, Sjogren's. But the CCP is greater than 250, which is probably the most sensitive marker to confirm a diagnosis of rheumatoid arthritis. So the workup I did, these are some of the initial lab results, I should say the rationale why I ordered these. I basically did a multi-panel, which was going to be your assessment of the organic acids, aminos, different oxidative stress markers, just to really have a targeted nutritional approach for this individual. We tested some food IgG panel. These really show us these food reactions are associated with inflammatory arthritis, and obviously they play a huge role in rheumatoid arthritis, so removing any offending foods is going to reduce pain and inflammation. We did a stool panel. Obviously, GI imbalances have been identified involved in rheumatoid arthritis. We did an adrenal stress index, which is going to really just measure cortisol, DHEA, and obviously when you're looking at gluten, and anything from grains has a really powerful stressor on the adrenal axis. So we also did an intestinal permeability screen, and this goes back to what I was talking about before, how you can really test for leaky gut. So here are some of the organic acids. These are really just some B vitamin markers on here. If we go down to number 20 and 21, 20 is going to be your methylmalonate. That's something that you can really test at Quest, but you get a lot more information when you go through some of these specialty labs. Per patient has a deficiency in B12, and 21's folate. So they're kind of creeping up there, but this patient definitely has some B vitamin needs. This is the neurotransmitter markers. 22 and 23, this is going to be your VML and your HML. These are what's going to be associated with your adrenal glands. And I mentioned that I did an adrenal stress index. To be honest, I don't do a lot of cortisol, DHA, salivary adrenal hormone testing anymore because the treatment's typically the same. A lot of these patients that come to see us have these burnout adrenals, and if you have really low, I like to say, suppressed cortisol over a period of time, or you have cortisol spikes, we're pretty much giving these amphoteric adaptogens that work in both ways to modulate. But really, that's what's telling us what's going on in the cortex. But the VML and the HML is what's telling us what's going on in the medulla. And that's really our catecholamine production. And this is showing us dopamine converting to epinephrine and norepinephrine. So if we look here, the HML is going to be more associated with our, I should say, dopamine catabolism, and the VML is going to be with the norepinephrine and the epinephrine. And some of these pathways are going to be, we have definitely products in our line that can address all these different specific cases. And that's how you can have a lot of success really treating patients specifically and not just with a generalized adrenal product. So in this particular case, I'm just going to go back here for a sec. VML is low, and we have this 24 is low, which is your 5-HIAA. That's your precursor to serotonin. So this person's indicated that they really need, their catecholamines are low, and they have low levels of serotonin. So this is a perfect example of someone that we would want to support with 5-HTP. And then the chironic pathway is high, which is specifically associated with pain perception and B6, and it's inflammatory pathway. So what we did here is we added a tonifying adrenal product to that, which is going to really bring up those levels. The vitamin C, B5, P5P, the riboflavin, these all play critical roles as enzyme cofactors really imbalance the production of stress hormones. There's the NAC, which is the most, or I should say NAT, or the N-acetyltyrosine is the most bioavailable form of tyrosine. So that's the critical building block of the catecholamines. And then licorice is really just going to potentiate and extend the serum life of cortisol. But we have adaptogens in there like Eleutherococcus, American ginseng, ashwagandha, rhodiola. And these are going to be used when you're using these functional labs and those two markers are low. We also, in this patient, we did a food sensitivity panel. They had a severe reaction to egg. And then the gliadin actually antibody surprisingly showed up on the salivary marker, so that was enough to kind of go off. It was actually positive 0.15, so this is more than double that. And this was a study done in, I believe, it was in the European Journal of Inflammation. And this just goes to confirm, I mean, this is right in the research in 2007, showing that patients with rheumatoid arthritis feel an association between the food intake and the rheumatic disease severity. And if you see here, in the study, they actually showed RA patients had food antibody reactions, IgG, IgA, and IgM. So this isn't something out of just the alternative, wacky science person who made this up. I mean, these are in medical journals. This is the research, and just these doctors aren't reading it. I did a stool panel on this patient. What we're looking at here is all the beneficial bacteria in the gut. The top 6 grouping of bacteria is what's going to move with your prebiotics. Your lactobacillus, your bifidobacter, that's what moves with your probiotics. So you can kind of see you really need to take where different probiotics, you really need to do stool testing to see what probiotics are going to be best for the patient and what type of diet. But obviously stimulating with probiotics, you can really affect those bacteria above there as well. And the lactobacillus, bifidobacter, all these bacteria really should be in the 4th and 5th quintiles off to the right. And you can see they're all within the first 3. So what this does, it pretty much gives more space for opportunistic stuff to come. But this patient obviously would be a good candidate for pre and probiotics. Total short-chain fatty acids is low. This happens anytime you have a bacterial overgrowth or just not getting sufficient amount of fiber. The fecal Sig-A was low. And IgA is the first line of defense for our immune system. That's the first thing that we come in contact with. So if you imagine your entire intestine, kind of paint it with just this covering that's really non-specific, it's non-inflammatory, it's not really that immune response, but that's your first line of defense. And it's suppressed in this patient. There's things that we can do from a nutritional supplement standpoint that can boost IgA, such as like a Saccharomyces boulardii. We can take colostrum and really just giving patients prebiotics, probiotics, and taking them off gluten. This is one of the intestinal permeability screens that I did on this patient, and this is going to really show you the breakdown of the different proteins and antibodies they test for. The actomyosin at the top, that regulates intestinal barrier function. So if someone has an antibody to that, it's going to show that intestinal barrier has some dysregulation there. So there's confirmed leaky gut there with it being out of range. The occludin and the zonulin, the occludin is part of the main component of proteins that really hold those tight junctions together. So antibodies to that are going to show that that's breaking down. Zonulin's the protein that regulates the permeability of the intestine, and when you have antibodies to that, it's going to indicate that the tight junctions are being compromised. And then obviously the lipopolysaccharides are antibodies to that are really just confirming that some of these endotoxins have permeated through the intestinal barrier and into the systemic circulation. So we definitely have some confirmed intestinal permeability with this. This was actually a study that was done earlier this month in September 3rd. And I just wanted to include it in here because this is just another autoimmune disease just with MS. but researchers at Lund University published new research findings on the role of intestinal barrier in autoimmune diseases such as MS. And the scientists there previously shown that probiotics could provide a certain amount of protection against MS. Therefore, they questioned whether the intestinal barrier was affected, which led their examination of inflammatory cells and processes in the intestine. As a result, they saw structural changes in the gastrointestinal mucosa of the small intestine to increase the inflammatory cells. So the great thing about this is, if you look at the end here, this doctor believes the future to treat MS should not be focused on just the central nervous system, but repairing and restoring the intestinal barrier. This is research that was done that was published 3 weeks ago, and a lot of these doctors that are working with MS patients or these other autoimmune conditions still don't realize that they have to really look at the gut. So treatment considerations, the traditional approach to really repairing the gut is going to be the 4R approach. That's going to be remove the first part, which is going to be remove things that cause inflammation. That can be gluten, in this case, egg, alcohol, aspirin, your non-steroidal anti-inflammatories from the diet. But then obviously, if this person had a yeast issue, you're going to be putting your different antimicrobials and things like that in there as well. The replace, if needed, digestive enzymes or HCl if they have not enough stomach acid. And then you're going to re-inoculate the bowel with pre and probiotics. And then things that you're going to use to repair is going to be glutamine, and we have a comprehensive GI product called GI Revive. You can use aloe, some other things like that. So treatment for this patient was a full spectrum multivitamin, some adrenal support. We did vitamin D, fish oil, probiotic, pretty much a lot of the standard basic foundation to just overall nutrition. We also did the GI Revive, which is a comprehensive gastrointestinal support with a probiotic and then extra glutamine. And then the 2-month follow-up after we removed egg, gluten, made all these nutritional changes, that C-reactive protein that was 35.6 dropped to 1.7, which I think is pretty amazing, because this doesn't there's no medications that just bring C-reactive protein down. You have to really address these environmental influences. So that's kind of a sample of just some of the types of different testing that I use with patients. And a lot of the docs that are naturopaths and integrative docs, they're pretty well familiar with some of these labs. The next patient that I worked with was with Sjogren's. This was a 31-year-old female, chronic neuropathic pain, that's the typical dry eyes, mouth, and skin. And then she has stomach issues, just like most other patients with autoimmunity. But here is the actual laundry list of medications she was on. And this is actually someone I know personally, a good friend of mine. And with all these medications, I mean, this patient was diagnosed with fibromyalgia, chronic fatigue, CRPS, Sjogren's, undifferentiated connective tissue disease, a small fiber peripheral neuropathy, RSD, Raynaud's, irritable bowel, chronic fatigue. So this patient is pretty much one of those people that she's on 12 medications. She's on disability because she can't work. She's getting IVIG infusions, ketamine infusions, and they got to the point where they were going to put her in a 3-day ketamine coma, and because nothing else was working. So we know when someone's taking this many medications, the amount of side effects they're having, I mean, they're not going to be getting healthier. So some of the stuff I did, I obviously just expanded on the limited profiles they were doing before. I did the organic acid testing, fatty acid profile, obviously, because that's going to play a huge role with the inflammatory response and really the structure and function of the nervous tissue. Then we did some food sensitivity testing. Some of the different organic acids here that were kind of out of range, we had some elevated L-lactate. I put some of the references down here so you can see the explanation. Succinate, and then the HMG. These are all associated with energy production, fatigue, weakness, muscle pains, neurological degeneration. But really, this just tells us there's mitochondrial dysfunction. And this person really needs CoQ10, B vitamins. Then when we looked at from a neuronal standpoint, her chirogenic pathway was high too. That's associated with your pain perception, inflammatory disorders, and B6. Some of her detoxification pathways were compromised. This is caused by obviously the mitochondrial dysfunction, and symptoms of the fatigue and weakness are really being shown with really how well this person is detoxifying. And obviously she's on a lot of medication, so why wouldn't she have issues with that? Then some of the other organic acids on here are bacterial metabolites, and this really shows us more what's going on in the small bowel. When we look at stool testing and you see yeast or bacteria in there, that's more of a snapshot of the large intestine, where this is going to really show us what's going on in the small intestine. So this patient's obviously going to be a candidate for probiotics. So here's a blood spot fatty acid profile, and just to kind of familiarize people with this, most people are used to seeing their lipid panels and cholesterol that a lot of their doctors are doing, but what's a lot better for really assessing overall health is really breaking down a fatty acid profile. So you can see here, we can measure your omega-3s in the blood. That's going to be 1 and 2. You got your EPA, your DHA. Now, realistically, she could use a little bit more EPA, but she's not really deficient in fish oils. And a lot of these patients that are coming into our practices to see functional doctors, they've seen like 12 other docs before they've seen us. So most of them know that they should be taking fish oils. But you can see here, she's still getting a lot of arachidonic acid, a lot of the omega-6s as well, and then there's a little bit of trans fat. So one of the most important things here is this ratio, number 9. It's your arachidonic acid to EPA ratio, and it's high. And so there's 2 options here. I mean, obviously, you want the patient to decrease these vegetable oils and these omega-6 fats as well as the trans fats, but they also probably should be increasing their fish oil up a little bit just to get that ratio more normal. In this particular patient, we did the IgG food antibodies, and she reacted to these 4 foods. Moderate reaction to egg and milk, and then a mild reaction to lobster and sunflower. And anytime you get reactions to multiple foods, like a handful, it's pretty suggestive you have intestinal permeability, so you really don't need to, in my opinion, do more testing for that. So treatment with her, we did a full spectrum multi just to get that foundation nutrition. Obviously all the medication she's on, she's going to be depleted of lots of different nutrients. We did a pretty good dose of fish oil, therapeutic doses of vitamin D based upon labs. In addition, a B complex, CoQ10, magnesium malate, and obviously I picked malate just because that's going to give someone more energy. So someone who has a history of fibro or chronic fatigue, taking magnesium with malic acid is going to give you a lot of that Krebs cycle intermediate, which is going to give us a lot more energy. And then I gave her an all-around amino formula and some arginine. From a GI standpoint, we went with the GI Revive, some extra glutamine, and probiotics. So what I wanted to really showcase a little bit more here as well is just some of these other products in our line. The GI Microbex is, when we're looking at stuff from a 4R approach, the GI Microbex is really the full comprehensive botanical that is going to be used for if you don't have stool testing done or a lot of the different bacteria that are showing up sensitive on the stool test fall into this category. This is a great product. It's got some tribulus in there, which really in the U.S., it's something that's been used to really more normalize hormone production or increase testosterone in men. But in all honesty, it does that very weak at best. But throughout Asia and all other countries, tribulus is huge from an antibacterial and antiviral standpoint. And the great thing about this, since it's not really being used for that in this area or the U.S., there's no resistance to it. We have some berberine in there, which shows a lot of antimicrobial activity against bacteria, viruses, and different parasitic agents or worms. Sweet wormwood, which is obviously the common name wormwood, is used to treat parasitic gastrointestinal infections. We have black walnut extract in there, which is another antiparasitic, but it also has a lot of activity against different fungal pathogens that are associated with your dysbiosis. Grapefruit seed extract is going to reduce fungal overgrowth, especially with Candida. And we have some caprylic acid in there, which is obviously naturally found in your palm and your coconut oil. But caprylic acid is really going to inhibit growth of Candida and other opportunistic bacteria that are in the gut. So once we move on to the next thing, we move on to oil oregano, and this is a 10-to-1 extract that we use in our formula, and this is going to be more commonly used with a lot of Candida and yeast infections with a lot of people. It's a very good antimicrobial with cleansing benefits. But I just wanted to point out that a lot of these concentrated oils that people use is very irritating to the gut mucosa. So we emulsified it with olive oil as a carrier. So this emulsification process is really going to increase that surface area and cause less discomfort for some of these patients. Allicillin's another great product that we have in our line. It's an antimicrobial that you would use to really get rid of yeast and really just any sort of immune boosting effect. And it's really a blend of your garlic macerate and garlic oil with specified levels of awin and diathins, which are really those active allicin metabolites. And this is much more potent than your typical 500 milligram capsule. And then olive leaf extract. This appears a lot on a lot of the stool testing sensitivity reports. It has a lot of antiviral properties. However, it shows up on sensitivity reports, so if someone's sensitive to it, it's a great product to use. And then we have our silver psyllin, and this is what a lot of us use for antimicrobial, antibacterial, antiviral. Silver psyllin, don't really confuse this with the traditional colloidal silvers out there. This is a broad spectrum antimicrobial, but it's pure silver in purified water. And the great thing about this is the silver particle is so small that it gets into the red blood cell and it can inactivate viruses at the cellular level. So when you have patients with Lyme and a lot of these other stealth infections, this kind of just helps cover the bases. Your normal colloidal silver is going to work by chemical action, and it really requires direct contact with those bacteria, and it can only kill one bacteria at a time, where silver psyllin is actually a structured silver of 4 atoms of oxygen and 4 atoms of silver, and since it can't come out of solution like colloidal silver can, it's going to kill or eradicate thousands more pathogens than your normal colloidal and ionic preparations. And this just kind of shows, some of the effects with MRSA, E. coli, and Staph aureus. Digestzymes. This is going to be a great comprehensive product just for overall digestive support. We have a little bit of HCl in there. You got your ox bile, which is going to really help digest some fats. Same with some lipase. And there's no porcine in here, so it's really hypoallergenic. Really, all these proteases are coming from an aspergillus or a fungal origin. There's some DPP4, which obviously helps break down your harder to break down proteins such as gluten and different rice proteins. And then Phloromyces is our Saccharomyces boulardii, which obviously has tons of benefits from crowding out Candida, eradicating C. diff, boosting IgA. And then one of our more recent products that we have in our line is called the Probiophage dairy-free, which is a probiotic blend that's dairy-free as well as these bacteriophages. And I don't really want to spend a whole lot of time going in on this because we have a nutrient roundtable that we did about 2 months ago, all on probiotics, and I can go through the details on this. We have a couple other probiotics in our line, the Probiotic Synergy. This is going to be more, these are all human strains, 5 billion per capsule, and this is going to be really good just for our maintenance. And then we have the Supreme where we need a little bit more at 15 billion. And we have something, a patented BioTrack technology. So this is going to deliver quite a bit more than your normal 2 capsule probiotics out there on the market. It's a slow release over a 10 to 12 hour period, and I mean, we pretty much reached out to the same technology that Big Pharma was using to get medications that they know had to get past the gut to work. And we use that technology for our probiotics. And so we know they're getting to the gut and where they need to be. And it just kind of shows the CF count when we use our BioTrek technology versus these other capsules. Then the GI Revive, this is really our full comprehensive GI support product. You have your glutamine, your N-acetylglucosamine, and then you can see a lot of these botanicals in here are going to be very healing to your inflamed, damaged intestinal mucosa. They're very mucilaginous agents and like sluggish properties. You have your aloe vera, your slippery elm, marshmallow, chamomile. These are very soothing, okra, and really reparative to the intestinal mucosa. Glutamine's the main fuel of the colonocytes of the gut. So really any single patient that has intestinal permeability needs to be taking glutamine, if it's in a GI Revive or if it's just in the glutamine product itself. I thought this was a pretty funny cartoon. The doctor will be with you in a few minutes. He's trying to figure out what disease goes with your insurance. That's one of the great things I like about working with in a functional medicine or integrated standpoint is whatever labs I order or whatever I recommend for patients, I don't let insurance companies dictate what I'm going to do or what I think is clinically relevant. And I feel like in the society we're in today, too many protocols or too many ways that doctors are going about treating patients is really just based upon what insurance and litigation and all these things. But realistically, when you do different labs from a cash standpoint that are relatively inexpensive, and then you do some of these functional labs, you can really help these patients and really getting these snapshots of their health that these other doctors aren't really looking at. And the big take home I have here with my presentation is not to get hung up on labels and really fix what you find and maximize the GI environment. And when you're looking at all these different conditions and autoimmune diseases, irritable bowel, Hashimoto's, rheumatoid arthritis, autoimmune diseases, Crohn's, for example, Hashimoto's, there's many things that can really be those underlying factors. And you have your gluten intolerance, like I mentioned, heavy metal toxicities. You can have a vitamin D polymorphism, insulin surges, estrogen surges, and GI infections. And these are all things that really have to get investigated. And I really wanted to do a workup because a lot of the presentations that I see are patients that are getting, or doctors that are getting educated on stuff. You see these presentations, but then it's not put into a context of how do I apply that in my practice? Or from a patient standpoint, how can this testing help me? So really what I wanted to accomplish with my presentation tonight was to show some of the doctors of some of the types of testing that I use, and also for patients out there of maybe how this might address some of the underlying causes in your conditions. And that's really the big take home. So I just wanted to thank everyone for spending their time to really get on this call tonight and really listening to the functional medicine approach to treating autoimmune diseases. And Ashley, if you want, you can start taking some questions for me.
Of course. Yes. Thank you, Dr. Mike. Excellent presentation as always.
Hi. I was wondering how much you think that the GMO corn with its Bt toxin is contributing to this increased intestinal permeability and even the ever-increasing use of glyphosate and the disruption of gut bacteria. How much do you think these things are playing a part in the increased permeability and the increased numbers of food allergies we're seeing?
Well, I think you make a really good point and bring up with the GMO corn, and obviously gluten and gluten's been obviously not the same type of, or wheat's not the same wheat that we used to eat, our ancestors did over 100 years ago. And the GMO corn, there's so much similarities between the proteins in corn and gluten that a lot of the patients that go to these gluten-free diets and they start, instead of giving up their processed foods and just eating these healthy alternatives, a lot of them they may still like their different snacks or their gluten food. So as an alternative, when they go to the gluten-free foods, a lot of those ingredients are corn products, and they tend to do all right, I think, for a few months. And then once they start consuming a lot of these corn products, since there's still an issue, or I should say cross-reactivity between these foods, I think people just start to get the same response that they get with the corn that they were getting with the gluten. And there's definitely some labs out there, or I should say a lab out there that does cross-reactive food testing where, let's say you have a patient that went gluten-free for a while and they're still having issues with foods. There's different foods like oats in your quinoa, your rye, your tapioca, coffee, egg. There's a lot of these other things that cross-react with gluten, and I definitely think they play a role with intestinal permeability. And I think most people had issues with intestinal permeability for quite a while, just by eating the standard American diet, stress, standard, the over-the-counter anti-inflammatories, alcohol, I should say aspirin in general. So there's lots of things that it's hard to say, but I think all these things are probably contributing to filling up the bucket. And then when there's a certain overload, and then it's just too much for the body. But I definitely think that like the GMO corn and definitely like xenobiotics, pesticides, and things like that are definitely playing a role in the autoimmunity and intestinal permeability.
Thank you.
Yep.
Alan Krieger?
Yes, thank you for a nice presentation. I would like to ask you about several of your products, the Digestenzyme, the Floromyces, and the Probiophage. All of these have either rice bran or rice flour or tapioca dextrin. And
Okay.
I can't use these with many of my patients because they tested positive for those cross-reactive grains. Are these items really necessary? What is their purpose in these supplements? And is it possible to switch them out with something that isn't a grain?
Well, I think when you see rice flour, I can understand your concern with that. These aren't fillers that we use in our products. Like take, for example, like a greens product. The rice flour is used in such a small amount that, like take, for example, certain like juice extracts or different things like that from a raw material standpoint, you need that to really I guess, get enough of that concentration. And you have to think this is listed in the other ingredients, so it's less than 0.5% that's in the serving. And the rice flour, there's no, this isn't like a whole protein of rice where you're going to get an antigenic response from it. This is really the way that this is used or in the processing. Like I said, it's less than like 0.5%, and it's kind of like when you look at like soy lecithin, for example. Soy, when you have someone has a soy allergy, you need enough of a protein to really cause that antigenic response. And a lot of times when something's, even though it's, you know, a raw material or processed, there's no protein residues left over that contains protein that really cause an issue with that.
So those three products then, the Digestenzyme, the Floromyces, and the Probiophage, there's not protein in those other ingredients.
That's correct.
Okay, thank you.
You're welcome.
I'm just wondering how you get a handle on looking at all of the different labs and then connect them with what needs to be done. Do you have a recommendation for working through the laboratory results and determining what's the best way to go?
So I think the big thing with a lot of integrative docs, and what I wanted to show here was just some of the snapshots of individuals' health that I really look at. For me, I pretty much deal mainly with autoimmunity and GI because that's what I feel strongest with, and that's what I work a lot with, and that's what I attract. Now, there's lots of different labs out there. There's lots of different tests out there, and you could do a workup completely different than I would and do different testing than I would, and you could still have a ton of success and get a lot of these patients well. And I think the thing with functional medicine where some practitioners get apprehensive is they feel like they need this direct like protocol on you have to do this, 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 and this. When I think over time, once you play around with a couple different labs, all the different labs have clinical support available for all your results, so they can walk you through with consultations. But I think the big thing is when you're dealing with autoimmunity, at least NGI stuff, all these patients need a stool test done, period. And there's lots of labs that can do it. And then obviously I really like to look at something that's going to assess nutrient status. And I like to look at something that may do like food sensitivities. And obviously that in my patient population is probably about 80% of their issue, because you can run all these different labs with different patients and do a whole workup, but you're not going to give someone 15 or 20 supplements at once. I mean, right. it's number one, it's too expensive, but it's too much stuff going on at once. So I think you really have to identify from the patient history and what they have going on, and finding out of everything they have going on, what's probably like 70 or 80% of their main issues, and then you work with that. Because when you deal with functional medicine patients, you have a relationship with them, and things evolve, and you try different therapeutic applications, and maybe in 2 months, then you're always tweaking stuff, and you're maybe adding something or removing something, and it's really a process. I mean, the body's dynamic. We're not trying to block pathways with drugs and just give them disease maintenance and symptom management. We're actually changing their physiology, and that process takes time. So I think there's multi-panels out there where I like to do a stool test, and then I like to do like an organic acid test that may have like food sensitivities, or if it doesn't have that, if I don't feel like food issues are an issue, I'll do one that will show heavy metals, RBC nutrients, and just a lot of other just nutritional profiles with the fatty acid profile. And so it kind of depends on if people's autoimmunity seems like it's more trigger related with foods, or if I feel like there's some other underlying things that are a little bit more important. But I really look at this to bridge the gap. I mean, I still expect all my patients to see their specialists and really still follow up with their visits there, because you're just part of co-treating this. And obviously a lot of the panels I showed today were with Genova. Some of them were old Metametrics panels that got inherited by Genova, but that's a great lab. They have some good support. I think Great Plains is another great lab. Cyrex does some good testing with cross-reactive foods and some gluten. So they're kind of like more of my favorite ones, and I think a lot of the integrative and NDs out there use them. But when you're looking at really an approach to go, I think you have to kind of pick. I think if you do like I think if you hit organic acids, foods, and stool, you're pretty much going to hit probably 80% of their issues, in addition to the traditional lab workup.
Great, thank you.
You're welcome.
Jan's question is ox bile, since it's from a bovine source, would that be particularly problematic for those reactive to beef?
I mean, I wouldn't think so. I mean, I would say this. If someone has an IgE reaction to beef, which I personally haven't seen, then I would say they shouldn't take this. But if they have like an IgG reaction, I would say it's such a small amount that's in that capsule that it probably wouldn't really, in my opinion, it wouldn't be something that would stop me, because there's enough stuff in there. I mean, really everything else, that's probably only like 2% of the entire capsule. And if that still is an issue or a concern for you, you could always go with like our plant-based digestive enzyme, which is going to have just more of those proteases that are fungal derived. So we have a lot of different enzymes in our product line, and we have the inflammatone, which is really good with food-mediated antibodies. So someone could take that in between meals on an empty stomach to really help with systemic inflammation. And then we have our allergyzyme. So there's lots of different enzyme products out there if you feel like that's not really good for you. But I would really think that if someone has an IgG, would be the only reason that would stop me from using that.
I have a question regarding the case that you presented. There was showing IgG, IgA, and IgM. On that case, IgM was low. I just wonder, I have patients with high IgG, other ones with low IgA. I don't have clear what is the significance of that, or what would be the next step with those findings, or with abnormal values on those tests.
So if a patient has, are you talking about like regular like food antibody testing?
No, you show on the first case, I think it's serum levels of IgG, IgA, and IgM, and on that case, IgM was showing low, but maybe different scenarios. Like I have a patient with high IgG and another one with low IgA. I do have them, and I don't know what that means. On a patient, they're all different cases.
Yeah. Now obviously that wasn't labs that I personally ran. They were ones I got forwarded to me when I first started on this case. And when you're looking at total IgA or total IgG and total IgM, I mean, obviously, like IgM is going to be a first responder, well, not fast, but it's going to be right after the IgA. And that can kind of really tell us, I mean, if you're looking at viruses, for example, that's going to show us if it's more of an acute attack, versus IgG can just be something that we have because we had a previous exposure to it. And I think you have to really look, I'd have to really see a lot of other, more of a full picture of a lab profile and other stuff that was being tested to really translate that. Because on a lot of these panels that I had, I only showed snapshots of, I should say, significant findings, but when you can't just look at one little piece or one marker and kind of make an assumption based upon it. We have to really look at a full pattern of an entire profile, and then that's why a lot of times I need to look at multiple panels here, because they all connect the dots and give us a big picture of what's going on. And one panel is only kind of opening a window to one little area, and it would be too hard for me just to kind of look at the total immunoglobulin. But I mean, IgG is going to be one of your most abundant.
Right. Thank you.
Yeah.
Renee, go ahead.
Yes. Hello. Can you hear me?
Hi, Renee. How are you?
Yes. Pretty good. It's nice that the circadian rhythm, in other words, assessing the cortisol indirectly through the organic acid panel, kind of like eliminates the assessment of a saliva circadian rhythm for that stress hormone. You, if I'm not mistaken, you hinted that there may be a possibility of determining the progesterone-estrogen ratio as well through the organic acid panel, or is that something I'm wishful thinking about?
When we're looking at the progesterone and estrogen, I mean, I would still be testing those in cases that you see that that's going to be clinically relevant. The only thing that I don't do a whole lot as much anymore is the cortisol salivary testing. I mean, I would still do like serum testing with the estrogen and progesterone, only because a lot of times, what I was hinting at before is, we can make an assumption of the adrenal cortical dysfunction, when catecholamine metabolites are abnormal. But the majority of patients we see typically have flatlined or low cortisol by the time they get to our office. And if the cortisol is high or low, the therapeutics we use are, typically applied in either pattern when it comes to cortisol. So the adaptogenic botanicals work indirectly to normalize cortisol in that aphoteric fashion through the hypothalamic corticoreceptors to normalize cortisol, whether they're high or low to begin with. So the assumption I'm making is more of, we can make that with the cortical function, but we can't really make an assumption with the medullary function. And a lot of times when you're giving therapeutic botanicals like your Eleutherococcus and your ashwagandha and some of your stimulating American ginseng, some of these botanicals, if people have ramped up catecholamines, these adaptogens can actually be stimulating, and it can make them much worse, and they can get palpitations and anxiety, and actually it makes that patient a lot worse, where they would really benefit from your rhodiola and then some of your calming botanicals like in our catecholacom, which would be like your passion flower, your lemon balm, and valerian, and coupled with some of the adaptogens. So that's kind of the therapy I've taken a lot with the approach, at least with the I should say the adrenal standpoint. But if I'm going to address like your progesterone or your estrogen, I'm usually going serum, or if it's something that seems to be like cyclical with their menstrual cycle, then I may do like a salivary 11 sample throughout the month to really see what's going on.
Or maybe a dry urine comprehensive estrogen metabolite profile.
Exactly.
Yeah, and just hypothetically speaking, if I see like a low kynurenine and a high xanurenic and a high quinolytic acid, then we can assume that we've got a lot of IDO, right? Endo-3-diamine deoxidase enzymatic activity causing a blockage of that tryptophan conversion. Therefore, if that tryptophan gets converted into that quinolytic acid, and it doesn't get converted into 5-HTP, and then downstream into serotonin. My question is that going to tell us that with that low serotonin, because of what we see in the organic acids, that low serotonin is not going to allow TSH to rise because there's going to be a blunting of the hypothalamic receptors, and then the thyrotropin releasing hormone will cause TSH to rise, and therefore T4, T3 will not be produced or released by the thyroid, and therefore it will be an indirect assessment of low thyroid.
You said a bunch there. Yeah, I mean, a lot of these organic acids have a lot of different mechanisms that are dependent upon, obviously, different cofactors and different things. And obviously, if things are low, I mean, it can definitely trigger a whole cascade of things. So it can definitely cause a lot of those things.
Okay. Thank you.
Yep, you're welcome.